Welcome to the deep dive. We take complex source material, break it down, and give you what you need to know fast.
And today, we're diving into a really core topic, sleep and sleep-wake disorders, all based on this comprehensive chapter from Pathophysiology.
Yeah, it's fundamental stuff. The chapter really emphasizes that sleep isn't just off time.
Exactly. It takes up, what, a third of our lives?
Mm.
And it's absolutely critical for, restoration, consolidating memories, tissue repair.
So our mission today is to really get into the nuts and bolts, the neurobiology, the different stages of sleep, and crucially, the pathophysiology. What goes wrong in disorders like insomnia, narcolepsy, and sleep apnea?
Right. The goal is mastery, understanding those specific mechanisms.
Okay, so let's start with that basic framework, the sleep-wake cycle. We know wakefulness is about mental activity, using energy. Sleep is the opposite, right? Restoration mode.
Pretty much. Sleep involves relative inactivity, but it's doing vital work. Memory processing, tissue repair, and importantly, a decrease in sympathetic nervous system activity. The fight-or-flight system ramps down.
So where in the brain does this control happen? What structures manage flipping that switch?
It's quite centralized, actually. We're talking about the brainstem primarily. The reticular formation, that network runs through the midbrain, pons, medulla. It's really the key modulator for wakefulness.
And sensory information, how does that play in?
Well, any sensory input has to go through the thalamocortical system. Think of it like a relay station to the higher brain, the cortex, the activity level there that kind of dictates if you're alert or heading towards sleep.
Makes sense. So how do we actually see these changes? How do clinicians measure these brain rhythms?
The main tool is the electroencephalogram, the EEG. It basically records the electrical activity of the brain waves, showing the ebb and flow of nerve firing.
And these waves have different frequencies, beta, alpha.
Exactly. We measure them in hertz or hertz. When you're awake, eyes open, taking things in, you see faster, lower amplitude beta waves over 13 hertz.
Okay, and if you close your eyes, just relaxing.
Then it slows down a bit into alpha waves, around 8 to 13 hertz. But the really interesting shift happens during sleep.
Right, that's when we see the theta and delta waves much slower, right, and higher amplitude.
Precisely. Theta is 4 to 7 hertz, and delta is even slower, 0.5 to 4 hertz. And that low-frequency, high-amplitude pattern is key.
Why is that? Why does that make us harder to wake up?
Because it signals highly synchronized firing. Imagine large groups of neurons firing together in unison. It takes a much stronger stimulus to break through that coordinated pattern. So you're less responsive to the outside world, more tuned out.
Got it. That synchronization is the shield. And this leads us to the two main types of sleep, NREM and REM.
Correct. NREM, or non-rapid eye movement sleep, is the bulk of it, maybe 80%. REM, rapid eye movement sleep, is the other 20%. A full cycle through both takes about 90 to 110 minutes.
And NREM is where the really deep restorative sleep happens?
Mostly, yes. NREM itself has stages. It's often called slow wave sleep. Stage 1 is very light, just that transition into sleep. Maybe it lasts, 1 to 7 minutes. You're easily woken.
Is that where those sudden muscle jerks happen sometimes? The hypnic jerks?
That's the one. Very common in stage 1. Your brain's kind of testing the waters, maybe.
Yeah. Okay, so after stage 1.
You drop into stage 2. This is a bit deeper, lasts maybe 10 to 25 minutes initially, but makes up a lot of the night overall. The hallmark here is sleep spindles.
Sleep spindles.
Yeah, they're these short bursts of high-frequency waves, like 12 to 14 hertz, visible on the EEG. Then you get at the deepest stages, 3 and 4.
And that's delta wave territory.
Absolutely.
Yeah.
Dominated by those high-voltage, slow delta waves. This is maximum relaxation. Heart rate, blood pressure drop, gut activity slows right down. Real physical restoration time.
Okay, so NREM is deep physical rest. But then there's REM sleep, which the chapter calls paradoxical. Why paradoxical?
Because the brain looks awake. Brain metabolism actually jumps up by about 20%. You see low-voltage beta waves, similar to being awake.
But your body is essentially paralyzed.
Exactly. There's a profound loss of muscle tone. The major motor pathways are actively inhibited. It's crucial, though.
Why crucial?
Because this is when vivid dreaming happens. The brain is super active, processing information, maybe consolidating memories. The paralysis stops you from, well, physically acting out those dreams.
Right, that makes sense. But sensory input is blocked too.
Largely inhibited, yes. So it's this intense internal experience disconnected from the outside world. Autonomic functions also go a bit wild. Blood pressure, heart rate, breathing become irregular, and you even lose temperature regulation temporarily.
Wow. And the source material is clear. Messing with REM sleep isn't good.
Definitely not. REM deprivation leads to anxiety, irritability, trouble concentrating. It's vital for, mental and emotional balance.
Okay, so we have these complex sleep stages. What keeps it all on schedule? How does the body know when it's time for all this?
That's the circadian rhythm, our internal biological clock. Interestingly, the chapter notes our natural cycle is actually a bit longer than 24 hours.
Longer, so we need to reset it every day.
Yep. That process is called entrainment. We need external cues, primarily the light-dark cycle, to sync us up to the actual 24-hour day.
And the master controller for this clock.
That's the suprachiasmatic nucleus, or SCN, right there in the hypothalamus. It gets direct input from the retina about light levels, so it fires more actively during the day.
So the SCN knows if it's light or dark. How does it signal nighttime to the rest of the body?
Mainly through melatonin. The SCN controls the pineal gland, which then produces and releases melatonin, mostly at night. Melatonin helps signal darkness and facilitates the shift towards sleep.
And we even have drugs that target this, like Rameltein.
Right. Prescription melatonin receptor agonist shows how important that pathway is clinically for tackling some sleep issues.
Okay, before we get into the disorders themselves, let's talk diagnosis. What tools are used besides just talking to the patient?
Well, the sleep history and a detailed sleep log or diary kept for at least 2 weeks are still foundational, super important.
But for more objective data.
We can use actigraphy. It's usually a wrist-worn device, kind of like a watch, that measures movement. It gives a good sense of sleep-wake patterns and duration outside the lab setting.
And the big one, the overnight sleep study.
That's polysomnography, or PSG. It's the gold standard if a significant disorder is suspected. It's really comprehensive.
What does it measure exactly?
Pretty much everything. EEG for brain waves, EOG for eye movements to catch REM sleep, EMG for muscle activity, often under the chin to track muscle tone changes, plus ECG for heart rhythm, sensors for breathing effort, and pulse oximetry for blood oxygen levels.
Wow, okay, covers all the bases. And what about testing for excessive daytime sleepiness?
For that, there's the multiple sleep latency test, the MSLT.
Yeah.
Basically, they give the person several scheduled nap opportunities during the day in the lab.
And what's considered abnormal there?
Falling asleep too quickly.
Yeah.
If the average time to fall asleep, the sleep latency is less than 8 minutes across those naps, that's generally considered pathologically sleepy.
8 minutes. Okay. Let's pivot to when things go wrong. Starting with the clock itself, circadian rhythm sleep-wake disorders.
Yeah, these are all about a mismatch between the internal SCN clock and the desired or required schedule, like non-24-hour sleep-wake rhythm disorder.
That's the one common in people who are blind.
Exactly. Without that reliable light cue to entrain the SCN every day, their internal clock tends to drift later and later, running on its own slightly longer than 24-hour cycle.
And then there's the classic teenager problem, delayed sleep-wake phase disorder, DSWPD.
Difficulty falling asleep at conventional times, difficulty waking up for school or work. It's very common in adolescents, partly because their natural circadian rhythm tends to shift later during puberty.
And we all know about acute shifts jet lag.
Right, especially traveling east. It's harder because you have to phase advance, force your body to sleep earlier than it wants to, which is tougher than delaying sleep.
And shift work disorder, constantly fighting the clock.
Yeah, it's really difficult to fully adapt the circadian system to night work, especially with conflicting social cues and daylight exposure on days off. The body struggles to keep up.
Okay, let's talk about the most common complaint, insomnia.
Right. Key criteria here. It's not just having trouble sleeping, it's difficulty initiating or maintaining sleep, despite having adequate opportunity for sleep. And it causes daytime impairment, fatigue, irritability, concentration problems.
And the difference between short-term and chronic?
It's about duration and frequency. Chronic insomnia means symptoms happen at least 3 times a week and have persisted for 3 months or more. Short-term is less than 3 months, often tied to a specific stressor.
And treatment. What does the source emphasize for chronic insomnia?
The first line is actually not medication. It's cognitive behavioral therapy for insomnia, or CBTI. This involves things like improving sleep hygiene, but also specific techniques like sleep restriction therapy and stimulus control therapy. Very effective.
Interesting. Okay, moving to narcolepsy. This is a central disorder of hypersomnolence, excessive sleepiness.
Yes, excessive daytime sleepiness is the core symptom, often feeling refreshed after short naps, but the sleepiness returns quickly. Type 1 narcolepsy is the classic form.
And type 1 has those other distinct symptoms.
Right. Cataplexy is the defining one, sudden, brief episodes of muscle weakness, usually triggered by strong emotions like laughter or surprise. People might also experience sleep paralysis or vivid hallucinations just as they're falling asleep, called hypnagogic hallucinations.
The chapter points towards an autoimmune cause, right, linked to genetics.
That's the leading theory, yeah. A strong association with the specific HLA type, HLA-DQB1-0602. It suggests the immune system might mistakenly attack neurons in the hypothalamus that produce hypocretin,
Hypocretin.
also called orexin. It's a neurotransmitter that strongly promotes wakefulness. In type 1 narcolepsy, there's often a severe deficiency of hypocretin.
And this explains the diagnostic findings on the MSLT.
Exactly. The lack of wake-promoting hypocretin leads to that very short sleep latency, falling asleep in under 8 minutes, and also the tendency for REM sleep to intrude inappropriately, like appearing right at sleep onset during the MSLT naps. That's called a sleep onset REM period, or SORM.
Okay, powerful connection there. Now, obstructive sleep apnea, OSA, this one sounds more mechanical.
It is. The key is airflow stops for 10 seconds or more. Despite the fact that the person is still trying to breathe, their respiratory muscles are working. The problem is a blockage.
Yeah, blockage where?
In the upper airway, the pharynx. During sleep, muscle tone naturally decreases.
Yeah.
In people susceptible to OSA, this relaxation, which is most pronounced during REM sleep, allows the airway to partially or completely collapse.
Ah, so the lots of muscle tone during sleep is the vulnerability.
Precisely. Leading to those pauses in breathing, often accompanied by loud snoring, gasping, or choking sounds as the person struggles to breathe and briefly arouses to reopen the airway.
What are the main risk factors mentioned?
Increasing age is one, obesity is a major one, and specifically a large neck circumference, the source notes over 40 centimeters, is highly predictive.
And the consequences go beyond just daytime sleepiness.
Oh, definitely. Untreated OSA is strongly linked to serious cardiovascular problems. High blood pressure, heart arrhythmias, heart attack, stroke. It puts a huge strain on the system.
And the standard treatment?
CPAP, Continuous Positive Airway Pressure. It uses pressurized air delivered through a mask to essentially splint the airway open, preventing that collapse during sleep.
Makes sense. Okay, quickly touching on movement disorders in sleep. Restless leg syndrome, RLS.
That's the one with the irresistible urge to move the legs, usually accompanied by uncomfortable sensations. Key features: worse at rest, worse in the evening, and temporarily relieved by movement.
Often linked to iron deficiency.
Yes, that's common association, along with genetics. Treatment often involves dopaminergic agents.
How is that different from periodic limb movement disorder, PLMD?
PLMD involves repetitive, stereotyped limb movements during sleep, usually flexing of the big toe and ankle, sometimes knee and hip. It tends to happen more in lighter NREM sleep, like stage 2. The big difference is awareness.
RLS sufferers feel the urge, PLMD sufferers often don't.
Exactly. People with RLS are bothered by the sensations while awake. People with PLMD are usually asleep and unaware. It's often their bed partner who notices the repetitive kicking or twitching.
Got it. And parasomnias, weird things happening during sleep.
Right, like nightmare disorder, really vivid, scary dreams during REM sleep, causing distress, often associated with PTSD. Then there's sleepwalking and sleep terrors.
And those happen in a different sleep stage.
Yes, typically during deep NREM sleep, stages 3 and 4, usually in the first third of the night. People sleepwalking might seem dazed, unresponsive, and crucially, they usually have no memory of it afterwards. That amnesia is typical for NREM disturbances.
Okay, last area. How does sleep change across the lifespan? Children.
Newborns have tons of active sleep, which is like REM. True circadian rhythms get established around 2 to 4 months. Sleepwalking sleep terrors are actually quite common in childhood, but usually fade by adolescence.
And older adults. Lots of complaints
Yeah,
there.
huge number, yeah.
Yeah.
Over half of folks over 65 report sleep problems. Objectively, their sleep tends to be more fragmented, with less deep NREM, stage 34, and less REM sleep.
Yeah.
But importantly, the chapter stresses that many sleep problems in older adults are often secondary to other things: chronic pain, needing to use the bathroom at night, nocturia, side effects of medications, other medical conditions, not just aging itself.
That's a really important distinction.
Absolutely. So wrapping it all up, this deep dive really underscores how sleep is this intricate ballet of coordinated systems. You've got the deep, synchronized quiet of NREM for physical restoration, and then the incredibly active yet paralyzed state of REM for, we think, memory processing and dealing with emotions.
And the disorders show what happens when that coordination breaks down.
Precisely. Whether it's the clot failing in circadian disorders, the wakefulness system collapsing due to hypocretin loss in narcolepsy, or the basic mechanics of breathing failing during sleep in OSA. Each points to a specific failure in this complex physiology.
Okay, so let me leave you, the listener, with a final thought based on that complexity. We heard that REM sleep involves both vivid dreaming and profound muscle paralysis, a necessary safety feature. Yet we also learned that this very loss of muscle tone makes the airway vulnerable to collapse in OSA. So consider this. How does the exact same physiological mechanism, the paralysis, essential for safe dreaming in REM, become the direct source of life-threatening risk in obstructive sleep apnea? It's a fascinating paradox built into our sleep architecture.
A great point to ponder.
Thank you for bringing your sources and joining us for this deep dive into sleep. We'll see you next time.